Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we chat with Andrew Jamieson, the clinical lead at the WA Country Health Service. Andrew has 12 years' experience working in the remote regions of the Northern Territory and Western Australia, and prior to this, he was the medical director at Netcare Travel Clinics.
In this podcast, we will be talking predominantly about travel vaccines and their use and some of the conditions that we prevent with travel vaccines. People often say, well, if I'm going to be running a travel clinic, which vaccines do we need to keep in stock? And that's always a bit of a risk, because the alternative obviously is for you to give a prescription to a patient and they can go and buy it at their pharmacy and then bring it back and you can administer that. I'm always a little concerned about that as a strategy sometimes, because I do know, and I've seen it in practice, that patients don't always necessarily look after their vaccines once they've got it from the pharmacy. The pharmacy itself might take pretty good care in terms of maintaining the cold chain, but then patients might pop it in the handbag or put it in the glove compartment of the car, or various things that make the vaccine less effective. That's a good clinical reason for you to hold vaccines. There are a number of vaccines that practitioners often hold that are part of normal immunisation programs. But if you had to ask me the vaccines that are worth holding just in terms of running a standard vaccination centre, I would say yellow fever, the current influenza vaccine. That's a bit of a no-brainer, everyone does that. Making sure you keep measles, mumps and rubella vaccine, because measles is really important. I would seriously consider maintaining stocks of rabies vaccine, because rabies is a high risk. Hepatitis A and B, you might well have stocks of that already as part of your normal immunisation programs, but if you don't, that is important. Typhoid, you might choose to use one of the combination typhoid vaccines. You might choose to use the oral typhoid vaccine. Now, the typhoid vaccine is something that, unless you're running a fairly busy travel vaccine service, you might not use that much, but it certainly is something to consider very strongly. Similarly, the meningitis vaccine. On top of that, there are other niche vaccines which are important. So for instance, Japanese bee encephalitis vaccine is really important, particularly for people who travel to certain parts of Asia. It's an infection that generally is underreported, because the vast majority of people don't get very unwell when they get it, but there's a small proportion of people that when they do get it do become very unwell. And then we've got other vaccines such as Q fever, which has a very specific risk profile, and one that I wouldn't generally advise for all travellers, but it is one that does have its niche. On top of that, it's also important just to make sure that people have got just their normal vaccination profile maintained, particularly in children. And for adults who are doing anything that involves high-risk activity, a tetanus booster, if one hasn't been had in the last 10 years, is also not a bad idea. So there's quite a broad range of vaccines that one would consider keeping.
So what determines the number of vaccines that can be given simultaneously?
People are always nervous about getting a whole whack of vaccines at the same time. Generally, vaccines are usually safe to administer together, and the availability of various combination vaccines helps. But the general rule of thumb to remember is you should not administer live vaccines again within 3 weeks of the administration of the first vaccine. Inactivated vaccines can be given all at the same time, but don't repeat live vaccines within 3 weeks of the second dose, because it has been determined that the activity of antibody formation is not as high if they're repeated too close to each other. Of course, one of the live vaccines that's really important is measles, and there are a number of measles cases that are on the go at the moment in Western Australia. The thing about measles is, I think the magic number that we use here in Western Australia is 1966. So if you were born after 1966, you would be considered non-immune, naturally non-immune, unless you're specifically aware of having contracted the infection. before 1966, the population is assumed to be immune because most people actually were infected with the actual virus. So if you're born after 1966 and you are not pretty convinced that you had the measles or had measles, and that's usually borne out by a blood test, then you should be aware of having had 2 measles vaccinations in your life. And if you haven't, then you need to make sure that you've had your 2 measles vaccines. Then you are protected. Measles is an extremely unpleasant infection to get at any time, but particularly as an adult. So that's generally the advice to travellers. And there are many parts of the developing world where measles remains rife, but places, there are many areas in Australia where the vaccine coverage against measles remains suboptimal. So it is a vaccine that is worth considering. The other vaccine that is always worth talking about with some specificity is rabies. Rabies is a dreadful, to all intents and purposes, uniformly fatal condition. There have been 2 or 3 cases of people surviving rabies now with intensive management, but it's pretty much still can be regarded as uniformly fatal. It's spread by the bite or scratch of an infected animal, and can easily be prevented by post-exposure vaccination. Now, post-exposure vaccination is always required, even if you've had pre-exposure vaccination, except the difference is that the post-exposure immunization that you get is in the form of a booster. So for travellers who are travelling to high-risk areas, and there are certain parts of the world that are very high-risk areas, parts of Thailand, parts of Southeast Asia are high risk, and it can be extremely disruptive to a holiday or a business trip if you do get exposed to a potential rabid bite or scratch, to actually go and have to get human rabies immunoglobulin and post-exposure immunization. It usually means having to at least leave the area that you're in and go to a major center. Often it might mean that you're having to travel to a place like Singapore to actually get the immunoglobulin. So it can be extremely disruptive to a trip. If one has a full course of pre-exposure rabies immunization, which is a course of 3 vaccines, should one be exposed to a potential rabid animal, either through a bite or scratch, then the post-exposure component is very simple to injections, compared to a person who hasn't had the pre-exposure. Then it requires human rabies immunoglobulin in and around the wound, and a large volume injection, then followed up with a course of at least 5 rabies injections over a period of just under a month. So, as I say, it can be very disruptive. It's really worthwhile for travellers to get that vaccine before they travel. There are a number of regimens that have been used. There's one around the use of subdermal rabies vaccine. So rabies vaccine is quite expensive. You can give a reduced subdermal dose. It's not an approved vaccine route within Australia, but it is quite an effective route, particularly when you get groups of backpackers coming in together. It's important that people understand, though, if they choose to go for that off-label route, that it's not an approved dosage and route here within Australia. There's another very rapid 4 subdermal site simultaneous vaccination protocol that has been used for people going to very high-risk situations. And some people do use that. I think that it takes a lot of courage if someone does get bitten by an animal, then not to require human rabies immunoglobulin after that. You can actually check rabies antibody levels through laboratories, and but normally labs will not allow that to occur, and specifically we certainly won't allow it to be built through the MBS system unless there's a very specific occupational risk. So, for instance, veterinary students going to work with animals in India, it's perfectly reasonable to make sure that rabies antibodies are at a reasonable level before travelling. So that's important. It's one of the biggest reasons why people's travel plans get disrupted is exposures to bites. Interestingly, the real risk of exposure from a simian bite, so an ape bite, remains very low, because at the various temples in Bali, for instance, people quite often get scratched or bitten by monkeys. There had been an outbreak of dog rabies that's been grumbling along in Bali for the last 4 or 5 years. It's much better than it was now. There's been a very concerted animal immunization program going on in Bali, but it's still it's a very low risk, a monkey bite in Bali. But I think a lot of people would still prefer to make sure that they're covered against rabies if they do get a significant exposure. Similarly, rat bites and rodent bites have also been demonstrated to be quite low risk. But again, because of the almost uniformly fatal nature of the bite, it takes a lot of courage to not get treatment for rabies afterwards. So that's one that I always think, particularly for people travelling to Southeast Asia, it's one. It is a risk that is worthwhile going into some depth with travellers around that risk. In terms of flu vaccination, sometimes people forget about the importance of flu for travellers. But it's really important to make sure that people have a current flu shot. Sometimes one can get hold of the Northern Hemisphere flu vaccination ahead of time. That's sometimes quite hard, but I certainly would recommend that everyone who travels has it. For people who are over the age of 65, one can consider a pneumococcal vaccination. People without spleens, it's really important to remember that they should routinely have pneumococcal, meningococcal, and for people who are old enough never to have had the Haemophilus influenza type B vaccination as a child to get a Hib vaccine, because the encapsulated organisms are at high risk of septicemic type infection in people who've had splenectomies. So it's important for that group to make sure that their vaccines are current. There's only one real universally compulsory immunization, and that's yellow fever. If you're traveling to certain countries in South America and Africa, you might need a yellow fever vaccination and proof thereof. So they generally are equatorial countries on those two continents. Now, yellow fever is a virus that is spread by the bite of a mosquito that also feeds on the blood of monkeys in the forests. And the monkeys are the natural host of the virus. So it means that, unfortunately, it's pretty unlikely that we'll eradicate the virus, even if we immunize the human population, because we can't immunize the monkeys. So there is a reservoir of virus in the monkeys. It's an unpleasant and highly dangerous infection, and as a result, it's the only one that's really subject to international health regulations on a constant basis. The reason why people are so concerned about it is that it doesn't exist in Asia, for instance, at all, but there are monkeys in Asia. So if the virus had to get into the monkey population on the Asian continent, you could end up with the same problem as you have in parts of Africa and South America. So for that reason, when arriving in some countries, even though it doesn't make a whole lot of sense to make sure you have the vaccine when arriving in a country, because as yet you wouldn't have been exposed and there's not much risk of bringing it in, people may still be asked for proof of immunization on arrival in certain countries. Certainly on going into the next country, so if, for instance, you visit Brazil and then you travel to, let's say, Germany, there's a very good chance that you will be required, if you visited Brazil within the last 6 days, which is the incubation period for yellow fever, that you will be required to demonstrate proof of immunization against yellow fever. Now, yellow fever vaccine is a controlled vaccine. You can't just buy it at the pharmacy. It's only usually sourced through state health departments, and the state health departments will supply individuals with it. You have to be a registered yellow fever vaccination centre, and when you are a yellow fever vaccination centre in Western Australia, you get issued with a supply of international vaccination certificates and a numbered stamp, and what you are effectively is a licensed yellow fever provider. The problem with yellow fever vaccine is that for many GPs, unless you're running a busy travel medicine service, you probably won't use an awful lot of yellow fever vaccine. But you need to understand that you need to hold a minimum level of stock, because if you're calling yourself a travel medicine centre or a travel medical centre, you will be expected to hold yellow fever vaccine. The other vaccine that is required from time to time under the international health regulations is polio vaccine. So we get outbreaks of polio from time to time still, unfortunately, because when I say unfortunately, I say that because we'd hoped by now to actually largely have got rid of polio throughout the world, but that's not the case. There's a current focus in West Africa around southern Nigeria, Cameroon, Niger, and there's another focus in northern Pakistan, Afghanistan. If you're a traveller visiting those countries, even though you might not go anywhere near the area where active polio spread is occurring, the country that you next travel to might not be aware of that. So there's a fairly good chance that you'll be required to have proof of polio immunization when you travel from one country to another. And that's not too hard. Inactivated polio vaccine is quite readily available. The other environment that does require proof of vaccination is for people servicing Hajjis and people traveling on the Umrah, which is traveling to Mecca in Saudi Arabia for Muslim travelers. It's a requirement made by the Saudi government, particularly during the Hajj time, where you get millions and millions of people from all over the world converging on one spot, and there's just a very significant public health risk at that time. So the Saudi government requires that people have meningitis vaccine, normally ACY and W135 vaccine. The problem with meningitis is that if it gets into people in close proximity with each other, then there's a significant risk of it spreading. Similarly, Saudi normally requires that people have had a flu shot now when traveling, because the risk of influenza is high. So it is a very specific requirement for people traveling on Hajj. But if one is running a travel medicine centre, it's really important that one is aware of those risks.
I hear there's a new medication for malaria prevention and treatment. Can we review current options in this area?
Sure. So malaria remains a significant risk. 90% of the fatal malaria cases in the world occur in Africa, but it still remains a high risk in South America and parts of Southeast Asia. Remember the 4 strains of malaria, which are falciparum, vivax, ovale, and malariae, which have been around for a long time. Interestingly, 4 is not strictly correct, because there's a new strain, Knowlesii, which was initially found in parts of Malaysia. Initially thought to be only in monkeys, but now we know it does infect humans and has a profile fairly similar to vivax, but actually can be quite nasty and has been associated with some fatalities. So that's just something to remember. So malaria is spread by the bite of a nighttime biting Anopheles mosquito. There are around about 220 Anopheles mosquito species that are implicated in the spread of malaria. Commonly, the common ones are about 14 or 15. But they all have slightly different behaviors in terms of biting. So some of them like to roost indoors and bite indoors. Some of them like to roost under the eaves of houses. Some of them like particularly dark places. Some of them bite after dusk mainly, and then not much again until just before dawn. Some of them bite peak times, sort of 10, 11 at night time. So there is a fair amount of variability with mosquito biting behavior, but certainly the nighttime biting behavior is the common one in terms of malaria mosquitoes. For that reason, prevention of bites is really important, and making sure that people utilize mosquito repellent, particularly in the evenings, cover up, long sleeves, long trousers, and sleep under insecticide impregnated mosquito nets really makes a big difference. The other thing that when people are living in areas, to make sure that they have vector control programs around where they live to actually reduce the mosquito population. That makes a very substantial difference too. So it remains a very dangerous infection, particularly falciparum malaria. So falciparum malaria, for people who live in areas of high endemicity, there's a very high incidence of childhood mortality from malaria. And then once adults who survive childhood are in the community, many of them will carry the parasite in their blood, but not be particularly unwell from it. And that becomes the reservoir for the malaria parasite. It's also important to note that, particularly when people move to a new country, that some people who were raised in that environment might minimize the risk of malaria. It's really important to understand that if you are a naive person moving to a malaria area, your risk of malaria is much higher than that of the local population. The thing about malaria is that if you're traveling usually for a finite time, taking malaria prophylaxis is generally advised when the risk is high. So there's certain areas that the risk remains low enough that you don't necessarily have to take prophylaxis. And an example of that would be, for instance, the Kruger Park in South Africa. Depending on the time of year, it's quite acceptable to simply use anti-mosquito measures, bearing in mind that if one gets any kind of febrile illness within 4 weeks of travel, to ensure that malaria is ruled out. In fact, even longer, it could be up to 6 months if one's traveling to an area where vivax malaria is more likely. The thing about malaria is that a higher index of suspicion should be maintained, and even if one uses chemoprophylaxis, that's not 100% effective. So any kind of febrile illness that might occur after travel should be regarded as malaria until demonstrated not to be malaria. In terms of using chemoprophylaxis, there are a number of options, and the options have become a little broader. In terms of what I would call the standard options, they're the options that look at killing the blood phase of the malaria parasite. So if one recalls the malaria life cycle, what happens is the mosquito injects parasites into the blood. Within about a 1 to 2 day period, those parasites go into the liver, they mature into the liver, and then after about a week to 10 days usually, maybe longer period, the parasites come out of the liver into the bloodstream and start multiplying in the red blood cells. Now, medication like doxycycline, which has been around for a long time, and mefloquine, the brand name was Lariam, that prevents against the blood multiplication phase. So it doesn't help in the early phase, and that's why you have to take doxycycline and mefloquine for 4 weeks after being in the area, because what you're doing is you're preventing the blood multiplication phase. You're not touching it in the liver phase at all. Recently, there have been medications that are now available that help to prevent the liver phase. So it actually stops the malaria parasite in the initial sporozoite phase, which is that initial 24-hour phase in the bloodstream and the liver, which means that when people come out of the malaria area, you only really need to take the medication for a week. And the medications that would be grouped in this area are, to use a brand name, Malarone. There are a couple of equivalents of Malarone. Now that's a combination medication that is pretty effective. The problem with it is that it's a medication that in Australia particularly is expensive. And if people are travelling for extended periods and a whole family is travelling, it can actually be very expensive. The alternative for Malarone, which we call a causal prophylaxis, that's a medication that actually prevents the liver phase, is the new medication called tefenoquine, which is a single constituent medication, which is somewhat similar to primaquine, which is an old medication and been around for some time, except it has a very long half-life. Now the advantage, it has a number of advantages. The first is that the long half-life enables it to be taken rather infrequently, tefenoquine. So after taking, for most adults, 200 milligrams, which is the tablet comes in 100 milligram sizes. You take 200 milligrams for 3 days before traveling to get the blood levels up, and then you only need to take it once a week while traveling, and then once again after one's return. It's quite effective and easy to take because it's just once a week. The downside of it is it's got a few side effects. The biggest precaution around it is of it in people who have G6PD deficiency. So if people have G6PD enzyme deficiency, it can cause significant hemolysis, dangerous hemolysis, particularly people of West African and Mediterranean heritage, but generally, to be safe, everyone should be screened before taking the tefenoquine. The other advantage of tefenoquine is that because it's active against the liver phase of vivax malaria, the so-called hypnozoites that actually go dormant in the liver and can come out 6 months later, taking 300 milligrams of tefenoquine at the end of the trip on returning to a non-malaria area is what we call terminal prophylaxis. So at the end of the trip, you can also make sure that you're not harboring any vivax parasites in the liver. The problem with the original chemoprophylaxis like mefloquine or Lariam and doxycycline is that doesn't really have much effect against the hypnozoites that are in the liver caused by vivax. So there remains a risk of it in those circumstances. So tefenoquine is I think a useful armamentarium. It's worthwhile reviewing the side effect profiles. A small number of people will get eye problems, GI problems, and interestingly, all of the quinine derivatives, it appears, have got the potential to make underlying mental health disease worse. So in the definitive trial that was done with tefenoquine, that looked at Australian soldiers in Timor-Leste, there was one suicide within that group. So it's a potential issue. Generally a rule of thumb for me that if people have got significant history of mental health issues, then I'd normally would advise doxycycline as a malaria prophylaxis. That any of the quinine derivatives are probably not a good idea. There's one thing that is not preventable by a vaccine, even though there has been some move towards the development of a vaccine. Interestingly, with not such great results initially in its use in the Philippines, but dengue fever is transmitted by the bite of a daytime biting mosquito, and it's a very unpleasant infection. Fortunately, the first time you get dengue fever, you just feel pretty rotten. If you get it twice, though, it can be quite dangerous, and dengue hemorrhagic fever is a risk. So the prevention of dengue fever is by using daytime mosquito bite prevention. Associated with dengue fever, there's a bunch of other daytime biting mosquito viruses. Again, no vaccines or prevention, but things like Zika and chikungunya, which is another virus spread by daytime biting mosquitoes. Again, they can be pretty unpleasant, so it's just worth making sure that in areas where the Aedes mosquito, the one with stripes on its legs that bites in the daytime, is around, then make sure that you use mosquito bite avoidance in the daytime. So dengue is found predominantly for us in Southeast Asia, Sri Lanka, India, but we do see outbreaks from time to time even in North Queensland. It's not common in North Queensland, but every year Cairns gets small outbreaks of dengue fever. It's also found in Central America and the Caribbean as well, and parts of Africa. So basically equatorial and sub-equatorial regions.
Thanks so much for coming and chatting with us today. A lot of valuable information.
It's a pleasure, Kate.